Κύριοι συνάδελφοι, να ξεκινήσουμε την επόμενη συνεδρίαση. Έχω μαζί μου στο Προεδρείο τον Σέργιο τον Τασιόπουλο, Διευθυντή της Παθολογικής Κλινικής στο Υγεία. Και η επόμενη διακεκριμένη διάλεξη είναι από τον Άλεξ τον Σπυρόπουλο. Οι περισσότεροι από εσάς τον γνωρίζετε όχι μόνο από τις εργασίες, αλλά και από το γεγονός ότι κατ' επανάληψη έχει έρθει στο Υγεία και έχει δώσει ομιλίες. Η ομιλία του είναι μαγνητοσκοπημένη. Δυστυχώς δεν μπορεί να σε zoom γιατί είναι σε μια περιοχή του κόσμου που θα ήταν 4 ώρα τα ξημερώματα και είπαμε να μην τον ξυπνήσουμε. Επομένως, λοιπόν, θα δούμε την ομιλία του βιντεοσκοπημένη. Μπορούμε να ξεκινήσουμε την ομιλία.
Καλησπέρα. Θέλω να ευχαριστήσω την Επιτροπή που με κάλεσε να δώσω αυτή τη διάλεξη για το συνέδριο της θρομβοκαρδιολογίας του Υγεία, προπαντός στην ΑΦΑ Καρδιολογική Κλινική του Υγεία με διευθυντή τον κύριο Πιπιλή και επίσης τους κύριους Προέδρους κύριο Σορμελή και Τασιόπουλο. Θα πω τη διάλεξη στα αγγλικά και αν έχουμε καιρό θα πάρω ερωτήσεις στα ελληνικά. Dear colleagues, I will be discussing an exciting new development in the area of informatics and healthcare, namely the development and implementation of an electronic health record agnostic clinical decision support tool in an area that I have been very interested both academically and clinically, namely thromboprophylaxis of the hospitalized medically ill patients. And in this way, I hope to have shown you how far we have come into bringing evidence-based medicine at the point of care for the practicing clinician. These are my conflicts of interest. And by way of acknowledgement, this was a multi-year, multi-institutional effort. I'd like to thank various institutions within my health system, Northwell Health, including the Feinstein Institutes for Medical Research. We received federal funding to implement and create the tool from the Agency for Healthcare Research and Quality, and lastly, funding from Janssen Pharmaceuticals to conduct the randomized trial. And by way of introduction, the practice of evidence-based medicine at the point of care has well-established benefits, particularly when it is implemented in the form of software-based clinical decision support that has been integrated into clinical workflows within electronic health record software systems. Now, previous work by our team that was funded by an HRQ grant included both the conceptualization and final development of Evidence Point, which is an EHR-independent CDS software platform that is capable of being integrated into clinical workflows within various EHRs at various clinical sites without requiring the solutions to be rebuilt for each deployment. This would make it easier to create and disseminate software-based CDS solutions that help promote the practice of evidence-based medicine at the point of care and incur high adoption. Now, venous thromboembolic or VT risk assessment of hospitalized medical patients using a validated VT risk score represents a classic test case of the use of our EHR independent CDS platform. This is a heterogeneous population with varying risk of VTE, and studies reveal inconsistent and non-standardized thromboprophylactic strategies of medical inpatients. And lastly, extended thromboprophylaxis has been shown to not only decrease venous thromboembolism or VTE, but arterial thromboembolism or ATE as well. We know from risk modeling studies that the use of intuitive, non-standardized universal methods of thromboprophylaxis in medical inpatients creates two errors. The tendency to overprophylax up to 50 to 60% of low VTE risk patients and thus subjecting them to the harms of chemoprophylaxis from a bleeding perspective, and conversely to underprophylax as much as 25% of high VT risk patients by giving them inadequate durations of thromboprophylaxis and thus subjecting them to the harms of thrombosis. It's for this reason that a system-wide approach for thromboprophylaxis is needed in this population. And towards this end, my clinical fellow, Nick Tsaftiridis, and I recently published a narrative review of system-wide thromboprophylactic intervention in hospitalized patients. We found 4 such interventions: the use of multifaceted interventions, which includes education, audit, and rounds, pre-printed order entry sets, the use of passive human or electronic alerts that have been around for the last 20 years or so, and more recently, in the last 10 years or so, the use of active clinical decision support tools that are EHR integrated. And out of all of those four models, what we found in our review that the use of active clinical decision support is associated with an over twofold increase of appropriate chemoprophylaxis in hospitalized patients and about a 32% risk reduction of VTE. And indeed, this appears to show the greatest promise to affect system-wide interventions for VT prevention, especially if these interventions are EHR agnostic, anchored on a validated and scored VTE risk model, and actionable, i.e. tied to VTE order entry. Now, we've known from randomized controlled trial data that is nearly 20 years old that the use of health informatics technology in the form of electronic or human alerts has potential to improve thromboprophylactic patterns. In the seminal study by the Harvard group, the use of an electronic alert that was tied to a scored VTE RAM at admission resulted in a 10% increase in the rate of pharmacologic prophylaxis and ultimately resulted in a 41% reduction of VTE. A second study by the same group showed that a human alert in the form of a physician alert, this time at discharge, also using the same scored VTE RAM, incurred a 12% increase in the rate of pharmacologic prophylaxis at discharge as well. But despite these advantages of the use of alerts, especially electronic alerts, these passive systems have multiple drawbacks. They're associated with operator fatigue. There's lack of interchangeability with alerts among various EHR systems, and also they're associated with major resource utilization, namely a human and informatics utilization. We now, of course, live in a very different health informatics environment from these early efforts about 20 years ago. We live indeed in an EHR agnostic environment with tools such as Smart on Fire, tools using HL7 interfaces that have interoperable informatics platforms, interchanges, and interfaces. Indeed, there has been a classic tension between CDS tool integration versus dissemination, in that a tool that is tightly integrated would be hard to disseminate, and conversely, a tool that is easy to disseminate would be loosely integrated. So the task of our health informatics team was to create a CDS tool that is both tightly integrated and easy to disseminate, as shown by C here. And towards this end, after many years of development, and again using the grant funding from ARC, we developed the Evidence Point platform, which is a novel EHR agnostic cloud-based integration, and the integration overview is shown in this slide. The user is able to launch a particular CDS tool from a typical EHR workflow, or a particular tool is able to be triggered automatically within the EHR. The launch request is specific to a specific patient visit. The CDS tool is forwarded to the Evidence Point application programming interface that we can see here, which then retrieves the patient data from the EHR data backend, pre-populates the tool with the patient data wherever possible, or the user is also able to fill in information manually. The CDS tool then calculates a personalized risk score for the patient, and this risk score is sent back to the EHR to be incorporated into the patient's medical record, as well as trigger any resulting next steps in the EHR, such as opening an order set. Indeed, this represents a schematic of the flow of data between the healthcare system, the electronic health record, and health informatics exchange. As we can see here, our platform is incorporated in the HIE environment that sits on top of any particular EHR. When any particular tool is triggered within the EHR, the tool calculator is used, results is sent out, and then this result goes back into the EHR to make both provider notes, recommendations, and open up order sets as necessary. Again, there is the monitoring aspects of the use of this platform outside the EHR. And lastly, this platform is able to be used in any healthcare setting, such as the ED urgent care setting, the primary care setting, the cath lab, radiology setting, as well as inpatient settings, and also to be able to be incorporated into various clinical care pathways. Now, in order to assess outcomes of the tool, we use the Proctor's methodology for implementation outcomes, where the most important implementation outcome remains tool adoption. So the proportion of providers using a particular CDS tool in greater than 60% of opportunities for tool use. But we also looked at other outcomes as well: tool acceptability, appropriateness, feasibility, fidelity, the tool delivery as intended, and lastly, penetration or reach. How far was the tool able to be used within various clinical workflows and various clinical sites. Now, importantly, as part of our ARC grant, we also developed a usability lab, because it's not only important to have an evidence-derived and EHR-agnostic tool, but is that tool actually usable? And within this usability lab, we were able to measure a specific CDS tool's user success rate and user error rate, also the time and task, which measures the efficiency of the tool, the overall usability of a tool, and lastly, design feedback. And towards this end, what we're able to do is obtain many healthcare providers' input into tool design, and we're able to, with iterative technology, improve the tool's feel and use, so that at the end of multiple usability testing, we had a tool that was easy to use and feasible and usable. This is a very important component of tool design. The last part of creating a CDS tool within our EHR platform was the ability to obtain a clinical prediction rule that was broadly validated. And in the area of VTE prevention in medical inpatients, we use the IMPROVE-DD VTE score, which is a well-validated, one of the most well-validated VTE risk scores available, been externally validated in over 120,000 medically ill patients globally. The original score used 7 clinical risk factors that were weighted and scored from 1 to 3 points, and the DD score also incorporated a relatively novel biomarker, elevated DD, to improve original model discrimination. As we can see here, a score of 0 to 1 predicted a low VTE risk population, a score of 2 to 3 an intermediate VTE risk population, and a score of 4 or more a high VTE risk population. This tool has been externally validated with area under the curves anywhere from about 65% to 72%, so good to very good, has been incorporated in multiple randomized clinical trials of thromboprophylaxis, and lastly, has also been externally validated in hospitalized COVID-19 patients using the original model thresholds. At the end of our iterative efforts, this is how the front-end IMPROVE-DD VTE CDS tool looks like for the front-end user. So depending on where the tool is launched, the IMPROVE-DD score is launched. The answers to the yes/no individual risk factors are pre-populated based on existing patient-specific data in the EHR. So again, the tool is able to extract the data from the EHR, and the user is also able to manually adjust the individual risk factors as needed. When the user clicks calculate probability, the IMPROVE-DD score and 3-month VTE risk percentages are displayed, and we can see here green for low risk, yellow for intermediate risk, and red for high risk. And when the user clicks record results and proceed, the tool closes, The score is written to the EHR, which is an important element for the hospital physician, and also, just as importantly, an appropriate prophylaxis recommendation is displayed in the EHR. Now, based on our usability testing, we incorporated 3 workflows for the launching of our ImproveDD VTS tool. The first was the VTE prophylaxis order set. As we can see here, that a provider was able to open the VTE prophylaxis order set, in this case for a medical inpatient, and then launch the tool. And depending on the ultimate score that the tool provided to the physician, there was an actionable order entry for the use of, again, if a score was 2 or more, inpatient thromboprophylaxis, usually with heparin, such as an enoxaparin or unfractionated heparin. The second workflow was the history and physical workflow, so that when a provider searched for an H&P in the adult note, again, there was a button that was able to launch the tool. And the third point was a brand new workflow, namely the tool launch at discharge. And this represented a brand new workflow so that we incorporated a launch button. The user was able to, again, launch the improved score. And depending on the score threshold, in this case, a score of 4 or more, if that was reached, and the patient did not have any exclusion criteria, as we can see here, high bleeding risk or inappropriate patient profile, the user was able to access the VTE order set and an extended thromboprophylaxis, in this case with rivaroxaban at the 10 milligram dose for approximately 30 days was recommended. And importantly, the user was not able to discharge the patient in terms of medication reconciliation until this was done. So this was a hard stop for tool use. Now, what was important is, at the end of the day, is not just to develop an evidence-derived tool, not just to create a tool that is easily usable and is used at appropriate workflows for the treating physician, but is there value of the tool? Does the tool actually change clinician behavior? But even more important than that, does this change of clinician behavior improve clinical outcomes? So towards this end, we were able to obtain pharmaceutical funding to conduct a large cluster randomized trial within our health system. This trial was presented as a late-breaking clinical trial abstract for the American Heart Association meeting last year and was published in the Journal of the American College of Cardiology Advances last September. As I stated, we conducted a clustered randomized trial at the level of the hospital. We selected 4 academic tertiary hospitals and randomized 2 of them to usual medical care and 2 using this CDS tool, as I described in the 3 workflows, both at admission and a brand new workflow at discharge. All providers underwent education for the ImproveDD score, and we measured outcomes up to 90 days post-discharge. The primary endpoint of the trial was the rate of appropriate thromboprophylaxis based on existing ImproveDD score thresholds. So a score of 2 or 3 would engender the use of inpatient prophylaxis with heparin, either unfractionated heparin or low liquid heparin. A score of 4 or more would engender the use of both inpatient parenteral thromboprophylaxis plus extended thromboprophylaxis with rivaroxaban up to 30 days as it is FDA approved in the United States. But we did not power our study for the primary endpoint. In this case, we would have only needed 800 to 900 patients. What we wanted to find with this clustered randomized trial is, does the use of this tool not only change physician behavior, but does it improve hard outcomes? So towards this end, we actually powered the trial for secondary endpoints, which included major thromboembolism at 30 days and major bleeding at 30 days as well, which is why we needed a clustered randomized trial of over 10,000 patients. Now, even though the number of clusters was relatively small, what we saw was that the actual numbers were quite big. We conducted this tool during the active phase of the COVID pandemic, and about 23% of patients were hospitalized with COVID-19. So in this slide, we see the primary outcomes of our clinical trial. The CDS tool adoption rate was quite high, approaching 78%. And what did this high adoption mean? Well, our trial met its primary endpoint. We were able to show a significant increase in appropriate in-hospital thromboprophylaxis in the intervention hospital group versus control group. Absolutely by 8%, from 72 to 80%, or relatively by about 50%. And secondarily, also appropriate at discharge extended thromboprophylaxis for high VTE risk patients, those with an improved score of 4 or more. Again, we saw an absolute increase of about 6%, or nearly doubling of this from a relative point of view. It's important to note that in the control group, these are very high rates of baseline, both in hospital as well as at discharge extended thromboprophylaxis of 72% and 7.5%. These rates are usually in the 50% range for in-hospital thromboprophylaxis and about 2% range for extended thromboprophylaxis, which suggests that the tool use would have even better effectiveness in non-academic tertiary settings. So what do these very high rates mean in terms of hard outcomes? Well, in terms of secondary outcomes, we saw that this increased rate of appropriate thromboprophylaxis in the intervention hospital group led to a reduction in thromboembolic events. We saw a 0.6% absolute or 20% relative decrease in venous thromboembolism, including deep vein thrombosis and pulmonary embolism. We saw an 0.5% absolute or an approximate 65% relative decrease in the rates of arterial thromboembolism, which included myocardial infarction and stroke, as well as systemic embolism. And for total thromboembolism, encompassing both types of thromboembolic events, we saw a 1.1% absolute decrease, or 29% relative decrease in total TE events as well, from 4% to 2.9%. Just as importantly, there's no evidence of excess major bleeding in both hospital groups. That was quite rare. Paradoxically, there was an increase in all-cause mortality in the intervention group, but we think that is likely due to more hospitalized COVID-19 patients in this group during the pandemic. So what was the research impact of the use of our tool? Well, our study has major health system implications, as it has shown that a novel universal platform agnostic tool for clinical decision support utilizing a validated VT risk model, namely ImproveDD, that is integrated into clinician workflow, demonstrated for the first time effectiveness in increasing adoption of evidence-based practice with an adoption rate of about 78%, and significantly increased appropriate thromboprophylaxis, and just as importantly, significantly reduced hard outcomes, namely venous and arterial thromboembolism in hospitalized medical patients. Now, because of this work and previous work using electronic alerts, the most up-to-date VT guidelines on the topic that were just published 2 months ago, namely the 2024 International Consensus Statement on Prevention and Management of VTE, chaired by Andrew Nikolaidis et al., gave a moderate recommendation based on moderate level of evidence for the first time that the use of health informatics technology in the form of either electronic alerts or clinical decision support tools may be considered at the hospital level to identify key populations of hospitalized patients that may benefit from both in-hospital as well as extended pharmacologic thromboprophylaxis. And this is especially important for hospitalized medical patients. So to conclude, ladies and gentlemen, we're entering a new paradigm in medically ill thromboprophylaxis, what I like to call an individualized, patient-level, risk-adapted approach using clinical decision support and interoperability, especially for advanced healthcare systems. We understand now that the acute hospitalization period still represents the highest thrombotic risk period, but now we can appreciate that up to about Half of events are now occurring in the immediate post-hospital discharge period in medical inpatients. We should still formalize VTE risk assessment at admission, but move away from a universal or group-based or intuitive model and use a more evidence-based approach, either using high individual risk factors or better yet using validated VTE risk scores such as IMPROVE and PADOA. And if a minimum score threshold is reached and patient does not have high bleed risk factors, they should be offered inpatient thromboprophylaxis either with unfractured heparin, better low liquid heparin, or second-line agents that include fondaparinux or rivaroxaban, which is approved in the United States for use. But just as importantly, we should also now formalize VT risk assessment at discharge as well, especially in those advanced health systems that has very short hospital length of stays for medical inpatients. And if patients have high VT risk factors using individual components such as advanced age, history of VTE or cancer, or better yet, using validated VT risk scores such as IMPROVE and IMPROVE-DD, if they meet minimum score thresholds, i.e. a score of 4 or more, they should be offered post-discharge extended thromboprophylaxis. Rivaroxaban is approved in the United States for this, but there is also a suggestion for the potential for using low liquid heparin in European settings. What are future directions within our project? Well, we recently applied for a very large multi-year, multi-institutional R1 grant to see if we, which is a part of a dissemination and implementation grant, to see if we'd incur widespread implementation of our IMPROVE-DD VTE CDS on our evidence point EHR agnostic platform. Thus, we can partner with large health systems to see if we can further refine the CDS tool, further incur usability testing, evaluate the usability and implementation of CDS tool in different clinical workflows and in different EHRs, which is very important, evaluate ultimately the use of evidence-based thromboprophylaxis, develop shareable CDS artifacts, and of course, there is the potential for both artificial intelligence and machine learning using the tool. So for that, I thank you very much for your attention. Thank you και σας ευχαριστώ πολύ.
Λοιπόν, πολύ ωραία παρουσίαση. Μπορώ να σας πω ότι ο Άλεξ Σπυρόπουλος έχει εξουδοτήσει τον Θάνο τον Πιπιλό. Ποιος ενδιαφέρεται για να δει αυτή την ομιλία, μπορεί να του δώσει μια κόπια ο Θάνος της ομιλίας. Πάνω στα informatics για την έγκαιρη διάγνωση και τη σωστή αντιμετώπιση των ασθενών με την θρομβοπροφύλαξη στους παθολογικούς ασθενείς. Θάνο, δεν ξέρω αν έχουμε 2-3 λεπτά. Okay. Να δείξουμε, αν θέλετε, τα 4 slides που έχουμε βάλει, που είναι το συμπέρασμα της ομιλίας. Με το Σέργιο καθίσαμε και βάλαμε 4 slides για να ξεκινήσει η κουβέντα. Πάνω στην αξία των Health Informatics. Αυτή είναι η πρώτη διαφάνεια πριν από 20 χρόνια. Δημοσιεύτηκε αυτή η εργασία που την ανέφερε ο Άλεξ από την ομάδα του Goldhaber και η επόμενη διαφάνεια έδειξε ότι όταν έστελναν ένα electronic alert, ένα electronic forced email στον θεράποντα γιατρό, με βάση μόνο τη διάγνωση εισόδου και αναγνώριζαν αν έχουν ή δεν έχουν κινδύνο. Και στους μισή ομάδα δώσανε ένα forced email, που σημαίνει ότι έπρεπε να απαντήσει ο γιατρός μέσα σε ένα τέταρτο, και οι άλλοι δεν πήραν. Και βλέπετε λοιπόν εδώ σε αυτή τη διαφάνεια, ήταν statistically significant η διαφορά με μόνο την αναγνώριση του κινδύνου της θρόμβωσης στους παθολογικούς ασθενείς σε αυτή την περίπτωση πριν από 20 χρόνια. Πάμε στην επόμενη διαφάνεια. Εδώ είναι, νομίζω, η πιο κύρια διαφάνεια από την παρουσίαση του Άλεξ Σπυρόπουλου. Αυτή είναι η πλατφόρμα που δουλεύει και άμα ακολουθήσετε τη σειρά που δείχνει, ξεκινάει από το 1 που είναι το request. Το request περνάει στο Clinical Decision Support Tool, από εκεί περνάει το 2 στο request, από το Evidence Poised που τραβάει τα αποτελέσματα και αυτά που ζητάει τα δεδομένα, που είναι το 3, όπου με την ταυτότητα του ασθενούς τραβάει από το EHR όλα τα data, τα ξαναπερνάει πίσω αυτά τα data του συγκεκριμένου ασθενούς στο Evidence Poised, περνάει στο CDC Tool και μετά γυρίζει στο EHR, όπου ο γιατρός παίρνει πια το score της προφύλαξης και της αντιπληκτικής αγωγής που θα πρέπει να βάλει. Πάμε στο επόμενο. Την επόμενη. Αυτή είναι η μελέτη που σας έδειξε, που το έγιναν σε 4 πανεπιστημιακά τριτοβάθμια νοσοκομεία, 10.000 ασθενείς. Η επόμενη διαφάνεια. Και η εφαρμογή αυτού του tool, αυτού της πλατφόρμας, η επόμενη διαφάνεια της πλατφόρμας που βάλαν σε λειτουργία, έδειξε ότι ήταν statistical significant η διαφορά και το adoption 77%, που σημαίνει και πήραν τη σωστή αντιμετώπιση και είχαν και πολύ καλύτερα αποτελέσματα. Αυτή η πλατφόρμα έχει τη δυνατότητα να ελέγξει και το πώς αντιποκρίνονται οι γιατροί, αν πράγματι το χρησιμοποιούν και όλα αυτά τα πράγματα τα οποία είναι σημαντικά στη τέτοια. Και την επόμενη, δεν νομίζω ότι έχουμε άλλη. Έχουμε άλλη. Η επόμενη. Νομίζω, δεν υπάρχει άλλη, ήταν τα outcomes. Επομένως, με βάση αυτά, θέλω να ξεκινήσουμε μια κουβέντα. Πρώτα να παρακαλέσω τον Σέργιο, που είναι και στην ομάδα του ηλεκτρονικού φακέλου στο Υγεία, πόσο μακριά είναι η ελληνική πραγματικότητα από αυτό που μόλις μας έδειξε ο Άλεξ.
Ναι, αυτό το οποίο μόλις είδαμε είναι ότι τα συστήματα υποστήριξης κλινικών αποφάσεων όλο και συχνότερα μπαίνουν στην καθημερινή κλινική πράξη, προϋποθέτουν την ύπαρξη ενός ηλεκτρονικού αρχείου ασθενούς, το οποίο όμως να μην είναι ένα αρχείο που απλά καταγράφει και παρουσιάζει δεδομένα, να είναι στην πραγματικότητα ένα αρχείο το οποίο αλληλεπιδρά με αυτά τα συστήματα, τα τροφοδοτεί ανά πάσα στιγμή με κλινικές, εργαστηριακές, θεραπευτικές πληροφορίες, έτσι ώστε την κατάλληλη στιγμή στον κατάλληλο χρήστη να παρουσιαστεί ένας συναγερμός σε μια αλληλεπίδραση, σε μια αντένδειξη, μια προτροπή, μια υπενθύμηση, ένα σετ οδηγιών, το οποίο να μεταφραστεί στη βέλτιστη κλινική πρακτική όσον αφορά στον ασθενή. Είμαστε πολύ μακριά από αυτό. Τα συστήματα τα οποία και στο δικό μας το νοσοκομείο, αλλά και στην Ελλάδα, όσο μπορώ να γνωρίζω, είναι κυρίως καταγραφικά και παρουσίασης πληροφοριών. Δεν έχουν την αλληλεπίδραση και τη δυναμικότητα που απαιτείται για τη λειτουργία τέτοιων συστημάτων υποστήριξης κλινικών αποφάσεων. Ελπίζω να πλησιάσουμε.
Νομίζω ότι έγινε μια καλή παρουσίαση αυτής της ομιλίας που ήταν ενδιαφέρουσα του Άλεξ. Δεν ξέρω κανείς αν θέλει να ρωτήσει κάτι και αν μπορούμε εμείς να βοηθήσουμε στην απάντηση. Εγώ, αν ρωτήσετε την προσωπική μου άποψη, νομίζω ότι αυτά τα πράγματα που ανέφερε και ο Σέργιος, η αλληλεπίδραση αυτών των συστημάτων, μπορεί να γίνουν μόνο με επιβολή, με κυβερνητικές αποφάσεις. Γιατί οποτεδήποτε αυτό αφέθηκε στην διακριτική ευκαιρία των συναδέλφων, τα συστήματα αυτά απέτυχαν. Μπορώ να σας πω την εμπειρία που είχαν στον Καναδά από το Registry των ολικών αρθροπλαστικών, όπου αποφάσισαν ότι πρέπει να κάνουν μια καταγραφή πριν από χρόνια. Τους είπαν ότι πρέπει να συμπληρώνεται αυτό το ηλεκτρονικό δελτίο για κάθε έναν ασθενή με τις ολικές. Δεν το συμπλήρωνε κανείς. Άρχισαν να τους δίνουν 10 CMEs, 20 CMEs να συμπληρώσουν. Κανείς δεν συμπλήρωνε. Τους δίνανε λεφτά μετά, $50, $100, τίποτα. Οπότε βγήκε το Υπουργείο και είπε ότι όποιος δεν συμπληρώνει αυτό, το νοσοκομείο δεν θα αποζημιώνεται. Και είχαν βέβαια μετά συμμετοχή 99%. Επομένως, αυτές οι μεγάλες αποφάσεις που αλλάζουν την υγεία θέλουν επιβολή από κυβερνητικές αποφάσεις, ώστε να γίνουν implemented αυτά τα πράγματα και να μην αφήνεται στη διακριτική ευχέρεια του καθενός νοσοκομείου.
Άλλος ένας λόγος γι' αυτό είναι ότι αυτά τα συστήματα θα πρέπει να συνομιλούν και να συνεργάζονται μεταξύ τους. Ένας ασθενής ο οποίος θα πάει σε διάφορους παρόχους υγείας για διαφορετικούς λόγους, θα πρέπει να αντλούνται δεδομένα και να παρουσιάζονται έτσι αποφάσεις οι οποίες να είναι σε συνεργασία από όλα τα δεδομένα του ασθενή.
Ναι, το ενδιαφέρον που τόνισε ο κ. Σπυρόπουλος ήταν ότι το 60% των ατόμων υπερθεραπεύονται ενώ έχουν μικρό κίνδυνο θρόμβωσης και υπάρχει ένα 25% που υποθεραπεύονται ενώ είναι υψηλού κινδύνου. Εσένα η εντύπωσή σου, Σάβα, είναι ότι δίνουμε συνήθως μια στάνταρ θεραπεία σε όλους για προφύλαξη αφού βγουν από το νοσοκομείο, χωρίς να λαμβάνουμε υπόψη αυτές τις ιδιαιτερότητες. Οπότε νομίζω ότι είμαστε και εμείς σε αυτό το επίπεδο ότι υπερθεραπεύουμε ή υποθεραπεύουμε. Ποια είναι η αίσθησή σου?
Είναι αλήθεια ότι πράγματι αυτό συμβαίνει. Πολλοί υπερθεραπεύουμε για τον κίνδυνο της δικαστικής εμπλοκής και βλέπω συναδέλφους, μιλάω για την ορθοπαιδική που ξέρω τα πράγματα, συναδέλφους οι οποίοι δίνουν προφύλαξη στις κακώσεις του ανώακρου. Αυτό είναι τρελό. Λέει για να μην πάμε στα δικαστήρια. Πράγματι λοιπόν, με αυτά τα εργαλεία λοιπόν θα μπορέσουμε να αποφύγουμε τις υπερθεραπείες και τις υποθεραπείες. Το άλλο μεγάλο πρόβλημα για τις άλλες ειδικότητες πλην της παθολογίας που έχουν τα δύο score, το Padua και το Improve, είναι ότι οι άλλες ειδικότητες δεν έχουν validated assessment score, δεν έχουν validated risk scores. Επομένως, εμείς οι ορθοπαιδικοί χρησιμοποιούμε το Caprini, αλλά δεν είναι validated. Και δεν υπάρχει καμιά αμφιβολία ότι πολλές φορές συνάδελφοι με ρωτάνε: έχω έναν ασθενή που θα κάνει μια αρθροσκόπηση, θα του δώσουμε, δεν θα του δώσουμε. Δεν θα του δώσουμε, δεν θα του δώσουμε. Ποιο ασθενή μιλάμε. Άμα μιλάμε για μια 60χρονη γυναίκα καπνίστρια, η οποία δεν κάνει καμία άσκηση στη ζωή της, ή έναν 20χρονο ο οποίος παίζει ποδόσφαιρο. Είναι τελείως διαφορετικά. Το risk assessment είναι πάρα πολύ σημαντικό. Αυτά τα εργαλεία θα μας βοηθήσουν να μπορέσουμε να παίρνουμε τις αποφάσεις μας χωρίς να καθόμαστε να σπασοκεφαλιάσουμε τι γίνεται και θα αντλώνται αυτά τα στοιχεία.
Και σωστά λες ότι είναι άλλο η ορθοπαιδική ασθενής και άλλο η παθολογική που μετά από μια πνευμονία συνήθως δίνουμε όνομα στο νοσοκομείο, ενώ μερικοί θα θέλουν ίσως και λίγο αργότερα μετά από μια λίμνη.
Ωραία. Επομένως, σας ευχαριστούμε πολύ. Διάλειμμα.
Μικρό διάλειμμα και θα είμαστε στην ώρα μας.